Let's just say I had the power to bequeath to you the ability to shift policy, treatment, laws, the whole gamut. What exactly would you propose and enact?
For helping people who have opioid use disorder, this life-threatening condition, we really have to see that treatment becomes essentially free. You saw messaging about how, grandmas need to lock their medicine chests so the kids don't get these pills, but no one really asking, why does every grandma now have opioids in her medicine chest? So we really haven't had a proper reckoning what went wrong. And so I think maybe that's why we're really not fixing these problems. Today in the United States, the most common cause of accidental death is an opioid overdose. So we're dealing with what I believe is the most urgent public health problem facing the country.
I'm Zoe Weil, and this is Solutionary Voices, a podcast brought to you by the Institute for Humane Education, an organization helping to build a more just, compassionate, and healthy world for all people, animals, and the ecosystems that sustain life. On this podcast, we bring together guests on the forefront of addressing local and global challenges and whose lives, ideas, and actions we hope will inspire you to find your own solutionary path. Today I'm speaking with Dr. Andrew Kolodny, the medical director of the Opioid Policy Research Collaborative at Brandeis University. Dr. Kolodny was one of the earliest and most persistent voices warning that the aggressive marketing of prescription opioids was fueling a wave of addiction and death. A clinician, researcher, teacher, public health official, and advocate, Andrew Kolodny has advised both state and federal policymakers, testified before the United Nations and U.S. Congress, and has served as an expert witness in litigation against the opioid industry. Welcome, Andrew.
Thanks for having me.
So our first question on Solutionary Voices is always, what problem are you working to solve?
I would say that the problem that I've been working on, and I've been working on it now for about 20 years, is really the problem of an epidemic of opioid addiction. And when I say that, what I'm really referring to is the fact that if you could go back in time, if you could go back 30 years ago, for example, that was a time when opioid addiction in the United States was rare. Where you mostly saw it was in low-income inner-city communities that had been hit very hard with heroin in the 1970s. And in those communities, there was a population of folks, sort of a cohort that was beginning to age, still struggling with their addiction to heroin. Outside of those communities, addiction to opioids was very uncommon, and death from an opioid overdose was uncommon. What would begin to happen starting in the late 90s was the number of Americans addicted to opioids began to go up rapidly, and it led to a public health crisis that we now refer to as the opioid crisis, and really is best understood as a sharp increase in the number of Americans addicted to opioids. And so that's really been the problem that I've been working on, trying to solve, both preventing people from getting addicted, but also seeing that people who are addicted can get effective treatment so they don't die from their condition.
So can you unpack the scope of the opioid crisis today and the systems that are perpetuating it? In other words, how do our economic, political, regulatory, and healthcare systems all intersect to contribute to this problem?
The scale of the problem is enormous. So what, as I mentioned, was previously uncommon, opioid addiction in the United States, is now very common. So it's about 5% of adults in the United States are suffering from opioid use disorder. That number changes depending on which part of the country you're in. For example, if you're in Vermont or Maine, it's a higher percentage than, say, in Nebraska. There are some communities in Appalachia where the prevalence of opioid addiction is about 20% of adults. Because opioid addiction is now so common in the United States, that has led to many health and social problems becoming much more common. So again, going back in time, an accidental death in the United States was overwhelmingly a car crash death. About 90% of deaths classified as accidents were caused by car crashes. Today in the United States, the most common cause of accidental death is an opioid overdose. So we're dealing with what I believe is the most urgent public health problem facing the country. And if we look at how we got into this mess, if we look at the different ways in which the system failed, our regulatory system failed in terms of the regulation of the companies that were making and promoting these products. Or if we look at the way in which our systems for regulating medical education, for example, systems we have in place that are intended to prevent pharmaceutical companies from having undue influence on medical practice through firewalls, so that medical education or journal articles are not easily influenced by companies. Those systems failed, and it would be very nice we were at a point where we had these important system failures that resulted in a public health catastrophe, literally hundreds of thousands of deaths, millions of cases of addiction. You'd like to think that we would be at a point where we would be saying, how can we learn from these mistakes so that nothing like this ever happens again? How can we change the way in which we regulate pharmaceutical companies or regulate medical education? How can we fix these systems failures? Unfortunately, though, that hasn't really happened. And what that means is that we're really set up for another public health crisis caused by improper marketing of prescription drugs.
It seems so counterintuitive, and you've dedicated decades to this, and I want to talk in a little bit about the arc of what's changed. You've been an expert witness in ongoing court cases, and I'm wondering if you can talk a little bit about these and whether there are common outcomes from these court cases that are leading to systemic change.
If you think about the litigation against big tobacco, and many people have been rightly critical of those lawsuits because the billions that were generated were not necessarily used as appropriately as they should have been used. And some people might point to that as sort of a failure. But if you really look at the tobacco litigation, despite the fact that the funds that were generated might not have been used that well, I think many would agree that there was a really important public health impact from the tobacco litigation. When the public learned how big tobacco had lied about addiction or cancer, or the ways in which big tobacco had targeted adolescents, for example, it made people angry. And it also led many people to quit smoking. And it also prevented many young people from starting to smoke. Of course, things have changed in recent years with vaping of nicotine products, but we really saw a significant decline both in starting smoking and also a reduction in tobacco use. So there's no question that the tobacco litigation did ultimately help save lives. For the opioid litigation, I think there have been some similar benefits. I think that as the public learned about Purdue Pharma and the way in which it lied about OxyContin and the way it minimized the risks of opioids, I think that's also been been very helpful. I think there's been, though, too much of a focus on this one company, Purdue Pharma, and the Sackler family, which owns that company, and I think almost a scapegoating of when in reality, as we discussed, there were many systems failures. It wasn't just about one bad company, but the system itself failed for different reasons, and there were many other companies doing exactly what Purdue Pharma was doing. And so I do worry that because we focus so much on this one company, that some of the public health benefit of the opioid litigation is lost. The other problem is that with the opioid litigation, many of these cases have settled. And when the case settles, if you don't have a proper airing of the facts and at a trial, many of the documents that could really help inform how these companies managed to improperly promote products in ways that were so harmful. We call these documents that are made available, that get subpoenaed in litigation, the discovery. The public never really gets to see all of the lies that were told when the case is settled. And often when a case settles, there's a requirement that those documents remain sealed. So I don't think we get to fully learn about what really happened behind the scenes. With the opioid litigation, there have been some pretty large settlements. We're at about $50 billion over the next 15, 20 years for states across the country from the different opioid industry players, which is a significant amount of money. But there's also a need to ensure that those funds get used properly. You don't want a state saying, okay, we've got this settlement, we're going to use it to lower taxes or fill potholes or cover budget losses in different areas. You really do want to see that these funds are protected so that you see that people who were impacted by the opioid crisis are helped.
That was going to be my next question. Is the money, the settlement money that's flowing into states actually being used in a solutionary way? And by that, I mean, is it really addressing the root and systemic causes and the impacts and coming up with solutions for the people who need it most, and then having those solutions be implemented? Sort of that would be a solutionary way. Is that happening?
It's too soon to really say whether it will take a few more years and an opportunity to look back and see how these funds were used to draw some conclusions. What we do know is that there are many counties that are getting their piece of the settlement dollars, and the counties are struggling with how to use these funds. In some cases, the counties haven't used these funds, or they've used very little. We certainly can't say at this point in time that the dollars are all being used as effectively as they could be.
Fentanyl has now largely replaced prescription opioids as the driver of overdose deaths, and opioid deaths are continuing to climb. Has that shifted your focus and work at all? And what do you think is the next solutionary answer?
It's certainly true that when you look at an opioid overdose decedent, someone who died from an opioid overdose, and if you look at the opioids that are most likely to be in their toxicology from a medical examiner, it is true that fentanyl is the opioid that's most likely to be found today. I don't know that I would really say, though, that fentanyl is the driver. What we do know is that for the majority of people dying of an overdose involving fentanyl, they're suffering from opioid addiction. Not all. There are a substantial number of deaths involving fentanyl where it might have been a young person experimenting with a counterfeit pill, and they lose their life to a fentanyl overdose, or someone who might have been intending to use a different drug that had fentanyl in it. And so, there are a substantial number of deaths involving fentanyl in people who do not have opioid use disorder or opioid addiction, but they are far fewer. Overwhelmingly, fentanyl deaths occur in people with opioid addiction. And when you look at the people who are dying from fentanyl who have opioid addiction, the majority are people who became addicted to opioids through use of prescription opioids. It's not people who became addicted by starting with fentanyl or even by starting with heroin. The majority are people who their addiction began with prescription opioids. There is a large number of people who were longtime heroin users who are also dying of fentanyl. They tend to be older, non-white men from inner city communities, longtime heroin users for whom fentanyl has taken a heavy toll. But when you look again, it's the majority of the deaths occur in people who were addicted to prescription opioids and then wound up on the black market. And as the black market supply of opioids became more dangerous because fentanyl became the dominant opioid on the black market, you saw the deaths going up rapidly in that population. So yes, I really think it's more accurate to think about opioid addiction as the driver rather than the particular drug. I would say that, in terms of my focus really hasn't changed, continues to be a focus on preventing opioid use disorder and seeing that people with opioid use disorder have access to effective treatment. If you think about the response to any kind of disease epidemic, those are really the strategies. If you think about, the AIDS epidemic, how do we bring that under control? What did we do? We worked to prevent HIV infection through clean syringes, through making condoms more available. And we saw that for people who had HIV infection, that they would have access to antiretroviral therapy so that they didn't die from it. And, if you look at how you respond to COVID, what did we do? We worked on preventing COVID infections, and then we came up with, through vaccines, and then we came up with effective, we had a fairly effective treatment for COVID. But really, that's how you respond to disease epidemics. And I think that's still the main approach. When we were experiencing a soaring increase in fentanyl deaths, that has changed over the past couple of years. But when those deaths were going up so rapidly, I think it did put more of an emphasis on expanding access to treatment. Because, if you really want to reduce those deaths in the short run, you want to see that someone who's opioid addicted can more easily access effective treatment. For example, with a medication called buprenorphine, you want to see that treatment is easier to get than fentanyl. Because if the treatment is easier to get, people will seek it. If getting treatment is expensive and complicated and you wake up in the morning and you're already dope sick, because, especially if you were using fentanyl, it doesn't last very long. So you wake up feeling sick. If you can make yourself feel better using more fentanyl, and it's very inexpensive and easy to get, whereas treatment is complicated and expensive, people will just continue using. So you kind of want to shift that. And with the soaring increase in deaths, I think that needed to be the focus. But overall, the strategies really do remain the same.
Let's just say I had the power to bequeath to you the ability to shift policy, treatment, laws, the whole gamut of systems contributing to the opioid crisis. And you are going to seek the ultimate solutionary change. What exactly would you propose and enact? And you've already talked about this a little, access to buprenorphine and the money being used for treatment, but spell it out for me. How can we really solve this problem? Let's say in 10 years, we're going to solve this problem. What does that look like?
The specific strategies for preventing opioid use disorder, if I could sort of wave a magic wand, what I would really want to do, actually, there's one new aspect of the opioid crisis that hasn't really gotten much attention yet, but it's an opioid that's available in convenience stores and gas stations and vape shops. It's called kratom. It's a leaf that has an opioids in it, and is causing many people to now develop opioid use disorder. I would make kratom products a Schedule 1 drug. The federal government almost did this back in 2016. Tried again in 2017. The kratom industry and the kratom lobby pushed back very effectively. And so then it got passed along to the states. Some states have banned it, for example, Vermont. But in many states, kratom is available. It's easily obtainable. And I believe that kratom is causing a significant increase in the number of Americans with opioid use disorder. And that's not helpful if we want to bring this problem to an end. Many people who are developing opioid use disorder from prescription opioids. And so I think there are policies that could be put in place to prevent that. One thing, if I could really do whatever I wanted, I would change federal law. One thing that I think would be very helpful is a new DEA registration policy so that physicians, nurse practitioners, dentists, if they wanted to be able to prescribe more than 3 days worth of an opioid, they'd have to take a special certification. And many would see no need to do that. And so the vast majority of prescribers in the United States would be limited to 3 days or less. And of course, if you treat cancer, if you're in palliative care, if you're in a specialty where it is necessary to prescribe more than 3 days worth, you would get that certification. And so I think that would also prevent prescription opioids from building up in people's medicine chests where they become a hazard and where people can easily become addicted to them. For helping people who have opioid use disorder, this life-threatening condition, we really have to see that treatment becomes essentially free. To use the AIDS epidemic as an example again, during the AIDS epidemic, the United States decided, we as a nation decided that if somebody was HIV positive, that they should have access to treatment regardless of their ability to pay for it. And we created a funding stream. It's called the Ryan White funding stream. And what that meant really was that anybody who was HIV positive would have access to antiretroviral therapy. And we have a system of clinics across the country where people can get treated for HIV and have all of their psychosocial needs met as well within these health systems. To this day, we're now more than 25 years into the opioid addiction epidemic. We still don't have a dedicated funding stream. What we started to see over the past decade was an increase in appropriations from Congress for 1 or 2 year money to states to help them tackle the opioid crisis. But 1 year, 2 year money, you can't really build out a treatment system. And because what will a state do? They can't really create a new treatment program, hire staff, and then if they don't get that appropriation the next year or fire everybody, we need a commitment from the federal government to long-term funding or the creation of new funding streams. And if we had those funding streams, if somebody who was opioid addicted could much more easily access effective treatment, it's essentially free, than it is for them to continue using, I think we'd see a dramatic decrease in deaths involving opioids.
I want to ask you about the issue of legalized drugs. So, there's the libertarian argument that drugs should be legal. There's the argument that people are dying, we can't allow these drugs to be legal. In between there is the reality that there are people who go to jail for possession and use of drugs. And I think that leads many to be more libertarian because they don't want to see anybody who's using drugs be jailed for that. What is your solution to that? That we keep these drugs illegal, but we are not incarcerating users?
It's not an either or. So if you just take cannabis as an example, I think that cannabis legalization has been a mistake. We've got now growing evidence that cannabis legalization has resulted in a very sharp increase in cannabis consumption and problems related to that. Even the New York Times, for example, which had endorsed cannabis legalization, I think in New York State, just a few weeks ago, came out with an editorial basically saying that that was a mistake. And what I think we should have done with cannabis was decriminalization rather than legalization. And so when you legalize a drug, you're allowing an industry to promote use of that product. And you have now a financial incentive for an industry to increase consumption. And in general, with many addictive drugs, and cannabis is addictive. Cannabis, I think it's fair to say, overall may have less negative physical effects than alcohol, but it is highly addictive and potentially more addictive than alcohol. If you look at the percentage of people who use alcohol that are addicted to alcohol, which is about 10%, with cannabis, it's probably a significantly higher percentage of cannabis users that are using on a very frequent basis to the point of having a negative impact on their quality of life. What you have with addictive drugs is industries that generally profit the most off of people who are addicted to those drugs. And so it's very hard for the cannabis industry to profit off of someone who uses a very small amount of cannabis a couple of times a month. The profits are coming off of the heavy user, the same way we see with alcohol and tobacco. So had we decriminalized it, had, for example, state governments said, look, if you grow it and use it, we're not going to come after you, but we're not going to allow an industry to promote it. We're not going to have stores that sell it and advertise it. I think many states thought, there'd be so much revenue that from taxing it, that it would be helpful in a variety of ways, but that hasn't panned out. So I don't think it has to be either criminalization or legalization. I think there is an in-between there, which is a more sensible strategy. I do think, though, for some hard drugs, that there should be criminalization. Not that you put someone who's addicted to fentanyl in jail for possession of a small quantity, but that the sale of fentanyl is a crime, and even possession of a significant amount is a crime. And again, someone who gets arrested for possession of fentanyl or heroin, it doesn't mean that they have to be incarcerated. If you look at Portugal, which came up with a very sensible strategy for a heroin problem that they were dealing with, they had a cohort of people who became addicted to heroin in the 1980s. They were aging. It was still a problem in Portugal. What they did was not legalization of heroin or even decriminalization of heroin. What they said was that if you were caught with a small amount, that they would mandate addiction treatment for you. And they got people treated. And so that was a positive public health response. So I think there are different ways of going at this. Obviously, mass incarceration of people with addiction is a mistake. But I think there are ways of getting at this problem.
I so appreciate everything you just said. And it's so solutionary, and it brings such nuance to this issue, which is something that the solutionary framework encourages, rather than having either or binary thinking, that we look at more nuanced ways of addressing problems. And I remember in Maine, where I live, when there was a referendum to legalize cannabis, and I had to decide how I was going to vote. And not wanting people to be in jail for using cannabis, I voted to legalize it. And I came to question that when, after however many years it had been, 30 years, 40 years since I had smoked pot as a teenager, I decided to try it again. And it was such an awful experience the whole time. And it lasted a long time. It was an edible in the form of lemonade. And I was literally clinging to my husband, who had not partaken, saying, I can't believe I voted to make this legal. I can't believe I voted to make this legal. It was so strong and so intense. And so I'm maybe like the New York Times, regretting how I once thought about this. And I so appreciate what you just said. So now I'm going to get to the other question I was thinking about when you were talking, which was the issue of finding this middle ground, this nuance between undertreating and over-prescribing. And I'm going to tell a story. So somebody I know, their son broke his leg when he was in high school, and he had to have surgery, and they sent him home with 2 weeks of Vicodin. He needed 1 day of an opioid, and then he had 13 more days supply in the medicine chest. So the same kid, 6 years later, had kidney stones and was in the hospital in unbelievable agony, throwing up from the pain, and they were giving him opioids, and nothing was touching it until they gave him Dilaudid, which was really strong. And that, helped him get through. He had surgery, but they did tell him there was one kidney stone still in there. It was a little smaller. It hadn't descended. It was going to happen in the next couple of years. So he and his family were going camping, and the kidney stone had started moving, and he went to the doctor, and they did blood work, and sure enough, this was going to be a kidney stone he was going to have to deal with. And they would not give him any opioid prescription. And the parents were saying, just 1 or 2 tablets, because we're going to be camping on an island, and we've seen how bad this can get. And what they said, and I think what I've heard you say in other contexts, is that using some NSAID and Tylenol is sufficient. And, this young man, it had not been sufficient. He was going to be camping. All the parents wanted was 1 or 2 tablets in case this happened. They said no. Then the parents pushed to get just 1 or 2 tablets. I mean, the parents don't want their kid to become an opioid addict. They just wanted this as a precaution. And in fact, while camping, it did get bad. He took 1 tablet, and it was sufficient. So that's a long story to ask this question about underprescribing and overprescribing, and where's the sweet spot there? And you did mention that in saying, no more than 3 days. But if a practitioner is saying, we're not going to give you anything for something that could be just severely painful, is that the right answer?
No, it isn't. And I think that certainly, there are examples, true anecdotes of a patient who should have received an opioid and didn't. Overall, though, in the United States, we are still massively overprescribing, and we still prescribe far more than any other country. There is this impression now that the pendulum has swung too far in a direction of underprescribing, that yes, we were overprescribing. It led to the opioid crisis, but now doctors won't prescribe for anything anymore. I don't really believe that we have a pendulum swinging back and forth. Even in the 1980s, before the prescribing really exploded, there were examples of aggressive prescribers, Dr. Feelgoods, who were out there. It's not like the medical community, necessarily moved in lockstep one way or the other. I do think that many people believe that opioids are the best, strongest pain medicines. That yes, they have these risks of addiction, and maybe even overdose if somebody takes too much, but these are the best pain relievers we have. And that's not really true. And the studies, even on acute pain, continue to show us that opioids are not the best. That even for kidney stone pain, the medical term for that is renal colic, which is excruciating, that NSAIDs are as effective and sometimes more effective with fewer adverse effects than opioids. So I do think that, opioids are not first line, even for kidney stone pain. And so we're seeing more appropriate prescribing now than we were seeing. So in this particular instance, for an adult who takes an opioid intermittently, if they're taking it intermittently, the risk that they're going to become addicted is lower. The risk that they'll become dependent is lower. And you don't have to worry so much about tolerance, which requires higher and higher doses. If you only took the opioid 1 or 2 pills every once a month, every other week, it's going to be much less of an issue. For young people, though, we do have to still, I think, try and be very cautious. We have studies that show us that if you expose an individual when they're a child to an opioid for a medical reason, even for an appropriate medical reason, that individual later in life, when, for example, they're a college student, is much more likely to misuse an opioid or wind up becoming addicted to an opioid than someone who was not exposed as a child, because you're basically giving them their first taste of the drug. And when we talk about some of the commonly prescribed opioids like oxycodone or hydrocodone, we're talking about drugs that produce effects that are identical to heroin. There really is very little difference between oxycodone and heroin. The effects are indistinguishable. So, if we consider that, then if we really think of oxycodone and hydrocodone as heroin pills, which I think we should, then there will be more cautious prescribing. And I think for an adolescent in other countries with good healthcare systems, it's very likely that for that camping trip, they would not have been given the opioid. They would have been given, an NSAID. Or if there really is an active kidney stone problem, maybe you don't go on that camping trip.
Okay, I'm going to switch gears a little bit. You have been criticized by some chronic pain patients and advocacy organizations as someone whose work has made their lives harder. And obviously, you don't want to contribute to anyone's suffering, which is why you've been doing the work that you have been doing. So how do you respond to people who are angry at you for taking away the drugs that they feel relieves their pain?
I can understand where some of these people are coming from. Quite a bit of the anger that's directed at me and some of my colleagues is not really based in reality. So on social media, there are sort of conspiracy theories out there about us that have no basis or very little basis in reality. And so that's harder for me to sympathize with. But we do have millions of Americans who are stuck on opioids. They were put on opioids for conditions where we now know better not to use them. And for these patients, as prescribing has trended in a more cautious direction, many of them are having a harder time finding doctors who will continue them on opioids. In many cases, some of the more aggressive prescribers are older docs who are retiring, and they may have a large caseload of patients on high doses of opioids, maybe opioids in combination with other sedatives. And when that doc retires, nobody wants to pick these patients up. If the patient calls another doc and says, I need an appointment, I'm on X milligrams of oxycodone and this much Xanax, and can I have an appointment so I can come in for a refill? Nobody wants they're like hot potatoes. And many of these people are very angry. And it is true that, I was, I was part of an effort to promote more cautious prescribing, so I could understand why they would feel so angry. Many of these patients truly believe the opioids are helping them because they wake up in the morning and they're feeling awful, and maybe their pain is horrible, and then they take a dose of an opioid and they feel better. And they'll tell you, if without that opioid, I wouldn't be able to get out of bed. I wouldn't be able to walk the dog. What I know is that a heroin user says the same exact thing. They're going to have heroin by the bedside because they wake up in withdrawal and they say, without the heroin, I wouldn't be able to walk the dog or take a shower. It's the same thing. So they may believe that the opioid is effectively treating an underlying pain problem, when in reality, the benefit they're getting from the opioid is the relief of the withdrawal syndrome, which includes, increased sensitivity to pain. If you have a painful condition, when you're in opioid withdrawal, that painful condition is going to be excruciating. And so they may believe that the opioid is helping them, but overall, we don't have evidence that it's helping them. The evidence tells us that the opioid is more likely to be decreasing their quality of life. The evidence tells us that the best way for people with chronic pain to improve is through more active treatments like physical therapy, exercise, lifestyle changes, other medicines, not opioids. But I can understand where these patients are coming from. And if they can't find a doctor who's going to continue them on a drug that they're essentially hooked on, a drug that they're going to experience excruciating withdrawal should they not access it, they're fearful, they're angry, and so it's easy to point to advocates for more cautious prescribing as being responsible for their plight, when in reality, they're victims of an era of very aggressive prescribing.
And since fentanyl is inexpensive and sold illicitly, does it then drive people to fentanyl with the greater chance of an overdose death? How do we intervene to make sure that those same people who are no longer being prescribed opioids then don't wind up dying from fentanyl that they obtained illegally?
It's not unreasonable to think that a patient who's getting opioids from a doctor and then can't find a doctor who's going to continue them might wind up on the black market and using more dangerous opioids. It's not unreasonable to think that could happen, and it probably has happened and does happen. But when you look at the epidemiology of opioid addiction in the United States, and when you look at basically the different populations of people with opioid addiction, the group that wound up on the black market after using prescription opioids, and that's really over the past decade now, been losing lives lost to fentanyl. Those tended to be a group of people who were in their 20s and 30s when they got addicted to prescription opioids, and were not really able to get pills from doctors. And so after getting addicted to prescription opioids, they very quickly wound up on the black market. Were using heroin, and then when heroin became replaced by fentanyl, the deaths in that group start to go up. We don't have good evidence that for the middle-aged and older population of people that were getting opioids prescribed to them aggressively, that they wound up really switching to the black market. Before fentanyl emerged, we were actually seeing more deaths in patients in the group that the middle-aged and older patients getting pills from doctors easily than we were seeing in the 20-year-olds who were switching to heroin. So these are different populations. And yes, if a patient who is hooked on prescription opioids can't get the pills easily from a doctor, potentially they could wind up on the black market using more dangerous opioids. But there's also the potential that they're going to wind up getting effectively treated. And, I could just tell you from my own experience treating opioid addiction in New York State in the early 2000s, there was a point in time where the state began to send letters to doctors whose patients were doctor shopping. The state had a database to see that, John Smith went to 3 doctors in 1 month to get opioids. And so the state sent letters to all of the doctors who had prescribed to John Smith and said, hey, your patient, John Smith, is a doctor shopper. Many of these doctors, unfortunately, fired the patient and said, hey, you didn't tell me you're doing this, and you're an addict. Don't come back to me. Some of those patients wound up on the black market, but some of those patients wound up seeking treatment. As soon as the state came up with that policy, myself and other doctors who were treating opioid addiction, we saw a lot of these patients who, when they came into us, we call it the chief complaint, what the patient tells you when they walk in the door. The chief complaint was, my doctor fired me. That's why I'm here seeing you. So we shouldn't assume that all of these patients turn to to a more dangerous supply. Some of these patients wind up with getting treatment. What we can assume, though, is because they don't get their opioid pain medicine anymore, doesn't mean their addiction is going to be cured. We do know that this is a population that we need to help.
Andrew, what has it been like as somebody who has spent decades trying to help people to be criticized in the ways you have when all you have been trying to do is good?
I can't really say that I'm that bothered by it. I suppose it's somewhat disturbing if I go onto a social media website and see people saying, there are comments out there that are pretty vicious. Often they're so detached from reality that, it's impossible for me to take it personally. Conspiracy theories that I'm involved in advocacy for more cautious prescribing because I have a financial stake in buprenorphine, a treatment for opioid addiction, or I have a financial stake in the rehab industry, or that I've been calling for more cautious prescribing because I wanted to be an expert witness in the litigation and make money off of the litigation. It's so detached from reality that it's really hard for me to be that affected.
So why are these systems so hard to change?
Why aren't we fixing these systems failures? Why haven't we learned from our mistakes? I think in part because we still don't have an adequate understanding of the problem. I think that for many years, as this problem was getting worse, the message that was pushed by the industry was that all of the harms that you're hearing about with regard to prescription opioids are limited to so-called drug abusers, that millions of patients are being helped, and that, yes, we have this subset of our population that are drug abusers. And, they're taking prescription opioids now because doctors are doing the right thing by prescribing more. But if you got rid of the pills, those drug addicts would find something else, was the messaging. And that worked for many years. So that, even up until around 2015, from some of the federal agencies that should have been tackling this problem, it looked like they were really buying that argument. You saw messaging about how, grandmas need to lock their medicine chests so the kids don't get these pills, but no one really asking, why does every grandma now have opioids in her medicine chest? And then we started to get to this recognition that the problem was overprescribing, that it was, that we put opioids in everybody's medicine chest. But then pretty quickly, it seemed as though there was a focus on the Sacklers and Purdue Pharma and this evil family and this evil company. And so we really haven't had a proper reckoning of what went wrong. And so I think maybe that's why we're really not fixing these problems.
Okay, so that brings me to my final question for you, which is, what would you like your epitaph to be?
One of the main reasons we wound up with an overprescribing problem and an epidemic of opioid addiction was that many in the medical community just went along with what everybody else was thinking and doing. The messaging that we could prescribe opioids aggressively and not have to worry about patients getting addicted never really made sense. And this idea that, if you prescribed opioids more cautiously, that you were allowing patients to suffer needlessly never made sense. And yet many in the medical community didn't question it. They went along with that thinking, with the groupthink. Nobody was saying, hey, look, the emperor has no clothes on. And so I guess I would like to be remembered as the guy that said the emperor has no clothes on. This really doesn't make sense. And that, I was willing to deal with the pushback, and I didn't shy away from a fight on what I believe to be right.
I love that. And we need many more solutionaries who are willing to say, the emperor has no clothes on. Andrew, thank you so much for being with us today.
Thank you.
Thank you so much for listening to this episode of Solutionary Voices. If you know of anyone who can benefit from this conversation about opioid addiction and how we can change the systems and end the problem, please do share this episode with them. And we invite you to subscribe, to write a review. And if you'd like to be a solutionary yourself, I invite you to read my book, The Solutionary Way. Thank you so much.